Discussing infertility is almost always a social taboo. Well, right here in Ghana, you really don't want to talk about it, especially talking about infertility amongst men. It's not something you want to go for. Thanks to medical advancement and progressive science, you really do not need to travel outside Ghana for help with fertility issues. Right here at the heart of East Legon, Mediport Fertility Services provides a top-notch service for all things infertility. Come with me, let's have a conversation. This is the Ohh Nana Podcast, and I'm your host, Nanefua Owusu. I'm very fortunate to sit down with two medical practitioners from Mediport Fertility Services. We're here to discuss everything fertility based. So I'm not going to take the thunder from them. I'll have them go ahead and introduce themselves. Welcome to the Ohh Nana Podcast.
Thank you very much. Hi, my name is Dr. Edwin Tiamwa. I'm an obstetrician gynecologist with the Mediport Fertility Services.
And I am Dr. Abigail Abiba Husseini. I'm a medical officer and a clinical embryologist in training, also with the Mediport Fertility Services.
Awesome. This is an amazing time sitting with two practitioners to really discuss issues that come up with fertility. So let's get right to it. When you hear infertility, typically in this part of the world, we already assume it's going to be a woman. So tell us, what is a typical ratio of infertility between men and women?
Okay, thank you very much. First of all, I want to give you a brief definition of what infertility is. So infertility is when couples are not able to achieve conception after having regular intercourse, unprotected intercourse for a year. Yes. But then for women that are above the ages of 35 years, it's 6 months. So if they are not able to achieve conception after 6 months of regular intercourse, if you are above the ages of 35, that is also considered as infertility. Now, interestingly, you realize that statistic-wise, both men and women have the same ratio. It's actually 1:1. It's about 40%. Yes. Both women have 40%, and then men also have 40%. And then we have like 22 to 30% of unexplained infertility. That is when you do all the investigations and you realize that they don't actually have anything wrong with them, but you still cannot pinpoint exactly what is causing their infertility. But most of the time, because of our cultural background, we tend to blame women more than the man, but it is actually 1:1.
Right. And I'm glad you mentioned because of our culture, we tend to blame women more. So the pressure is usually on women based on our culture. So let's talk a little bit about male infertility. We usually don't talk about that because it's almost like a taboo. What are the usual causes of infertility in men?
Okay. So for infertility in men, you can have what we call congenital. That is something that you got even before you are born.
Wow.
Right? And then we have what we call acquired. So you get it whilst you are born. So for the congenital ones, it usually happens before you are born. So if you have any form of infection that actually happens to the woman before birth, yes, that affects how the man is actually formed. Whether they actually have testes, whether they even have penises. Once you have that, you can have issues with their male fertility. There are also people that look like men, but are actually women, genetic-wise. And so you realize that when you actually examine and then test them genetically, they are carrying more female genes than they are men genes. So those people also have male fertility.
That just confused my brain a little bit. Is it that they have female productive systems, or it's like male reproductive systems?
So that's a whole interesting topic on its own, because you see, we have the genetic sex, and then we have what we call gonadal sex, and then we have what we call phenotypic sex. So the genetic sex is what we all know as XXXY, right? Everybody carrying XX is a woman. Anyone carrying an XY is a male. Then you have the gonadal sex, where you are supposed to break down whatever it is that your brain tells your body to form. So that is when they form the uteruses, the ovaries, the fallopian tubes. For men, we form penises, we form testes, right? But it is under an action from your brain, okay? They have the phenotypic sex, what we see on the outside that determines whether a person is male or female. So somebody can actually have the phenotypic sex, look everything like a male. But when you check their genetics, you realize that they are actually female.
Wow, that's interesting.
Yes. So those are the congenital parts. Then the acquired ones, for instance, you can have injury to your pelvis as a man. Smoking, use of recreational drugs like cocaine and alcohol can also reduce the level of sperm production that you actually have. And then there are some boys that are born with, and they said the testes. Yeah, so if your testis does not descend, they also affect how your sperm production is formed. And then when you are a child and you suffer from mumps, there is this viral infection that you have. They also affect your formation of your sperm production. Wow. So these are some of the things that actually affect male fertility.
That's definitely interesting because I never knew about the ones you can have even prior to being born. Are there specific treatments for these? Is there a way out? Let's say a man has an infertility issue at any point in life. Are there specific treatments that can help?
Yes, there are.
Sure. I think, like we stated earlier, the pressure seems to be on the women more than the men. The reason being that usually when men have issues trying to get their partner pregnant, we are able to solve the problems easily as compared to women. So, like you mentioned, when like all these factors affect the production of sperm, and the male is unable to produce enough sperms, what we usually do, okay, so in some patients, we give them medications.
Okay.
We recommend some supplements, any medication that contains vitamin C, vitamin E. They are antioxidants that help in sperm production. Medication that contain CoQ10 are also known to also help, as well as any medication that contains folic acid, folate. They help in the maintain the DNA integrity of the sperms. So that's actually the first step. We give them a couple of medications to help boost the production and the quality of the sperms. However, when they come in, we do like a semen analysis, and then we are unable to produce enough sperms, or maybe we get enough sperms, but then let's say the motility, that is the way the sperms are swimming up, is not very good, or even if the number is not very good, or even if the DNA is not intact, the science has helped us, or we are able to take the sperms to the lab. We look at it under the microscope, we prepare it in different stages, and we're able to select the best sperms. And then again, in males who have like prostate cancer, who may have to do a prostatectomy, that is taking out the prostate, we are so advanced that we are able to get the sperms out. We prepare the sperms and then we store it before they go for the procedure. So if let's say like 50 years or you're very 45, very young, and you have like a prostate cancer, you're supposed to go and do a prostatectomy or something like that, or a prostate biopsy. We're able to take out your sperms, you produce enough quantity for us, and then that is it. We process it, we select like the very best ones, we prepare them and we store them for future use. That notwithstanding, there are some cases where they might take the medications and then still not producing enough sperms, or maybe the concentration, so that's the amount is not enough, or the motility, that's how fast the sperm swims, are not enough. In such cases, we do sometimes recommend donor sperm for them, but then again, it's a battle. Yeah.
Oh, battle for the men.
Exactly.
Okay. So they do not want donor sperms in most cases.
Most cases they do not want, because I think it bruises their ego a little. So they would rather shy away from it. I think you can also say that a bit.
Okay. Do we see this as a commonality within this industry where men who have infertility issues shy away from that because they just want to have their own sperm?
Yes.
Definitely.
Yes.
Wow. So men, please work with our fertility practitioners. Anyways, this next question I think is very important, and I want to take my time with this. It's about stigmatization of women when it comes to fertility. So I'm not really sure about other parts of Africa, but I can speak when it comes to Ghana. Growing up, I know barrenness is almost like a stain for most women. And there's a pride in giving birth. Of course, it's a blessing for most families. But when you don't have a child, or you're not able to have children in our community, you're seen as a laughing stock. And majority of the stress is on women. So, my question is, what services are available here for women who are struggling with this journey of becoming moms?
Okay, so at Mediport Fertility Services, we actually call this place a home. I mean, a home that provides solutions to all your fertility needs. We focus not only on the biological or the pathological aspects of the case, but then we look at the social aspects. So the first step we have here is we have a support group for every woman who works in here. It's a WhatsApp group for now. We have our team. Um, we have the specialist, our senior specialist, Dr. Erika Mapa. We have our senior clinical embryologist, Dr. George Selom. And then we have Dr. Intiama, we have Dr. Iwa, and then myself, and then all the fertility nurses are on the page. Our numbers are accessible to all our patients. It's not limited to just the patients here. We are trying to open up to every woman out there who is struggling or who is having issues or going through any kind of difficulty because they are unable to have kids or they are experiencing some delays, let me just put it that way, in conceiving. So what we do is, like I said, our numbers are available on the platform. We have patients who reach out to us personally, and we have online consultation, which is free. People who have challenges, days that they break down, they call us, we counsel them. We offer psychological support. Once in a month, we meet together on Teams and we have discussions where we share our experiences. I mean, we have some of our patients freely talk about what their fertility journey has been. And it serves as a way of, first of all, encouraging us, reminding them that they are not alone on this journey. We have a whole team supporting you. So that's the first step we have taken to support the women. And I'm very passionate about that personally. And then we come to the medical aspect, of course. So after you think of your social well-being, make sure you are very comfortable with us. We now welcome you to our consulting room where we sit and then we take a very brief history. We would like to know your journey so far, what your story has been, whether or not you've been pregnant, if you have any issues. We run a couple of labs to first of all find out how good your eggs are. Is there any issue? I like to use this to talk about it. I mean, so for women, unlike men, where all they have to do is just produce sperms for us and then we are good to go. For the woman, unfortunately, it's a lot of things, right? It starts all the way from the vagina, all the way to the ovary, and then coming back here, right? So, stated earlier, after you take care of your social well-being, then we now sit you down. Actually, here most of our consultations are like one-on-one. We have enough time for our patients. There's no need to rush. We could spend like 30 minutes to 1 hour on the patients just to walk you through everything. So I think I'm just going to do that here for the listeners as well.
Definitely.
So let's imagine you are a patient for the day, right? So then when you come, you would first of all want to find out your history, like I mentioned, your background, and you tell us your story. I mean, whatever you think you need us to know. If there is any further questions, we ask, but we don't put pressure on you. Like I said, it's a home. So first of all, we have to make sure you feel very comfortable. Everything fertility about women has got to do with, first of all, the sperm moving all the way from the vagina through the neck. That's what we call the cervix. All the way here, this is the inside of your womb, all right? And then this is the fallopian tube. Okay, you produce the eggs here. That is the ovaries, all right? So when you produce the egg, it has to be released. So the sperm will travel all the way here to meet up with the egg before it will now fertilize and form a tiny baby, which we call the embryo. The embryo will now have to move back to implant here, which is the uterus. So we can see it's a very long trajectory. Anything that affects this whole path or at any point in this path can affect your fertility. So in that case, what we do is we try to now conduct a couple of tests to find out or identify any problem. And based on what we find, we suggest solutions. We have different solution options that we would go into later on in our discussion.
Sounds good. Definitely. Thank you so much for it's such a well-rounded explanation of the type of services that women will typically receive here. And I have to commend you for the social aspect. Sometimes we really don't think about the mental trauma of what women have to go through when it comes to the fertility journey. So I really want to say thank you both so much for this type of services for women. Now let's move on to general conversations. How should couples usually prepare for their journey to parenthood? Let's say, for instance, what tests are done to make sure parents are not passing on certain types of diseases or maybe unwanted things to their kids?
Thank you very much. So before any couple comes in for fertility, I think the most important thing we all have to do is what we call the preconception care, right? So the preconception care takes into account how fit a couple is to actually get pregnant. So if I break it down, if you take the man um, aspect of it, the man has to be fit enough to be able to get the wife pregnant. We seem to undermine or underplay most of the medical conditions that men tend to suffer if you have certain conditions. One of them is obesity, yes, and overweight. So you need to at least lose weight. If you are smoking, you are using marijuana, you are drinking alcohol, you need to stop all that, right? And then there are certain medications that you are on that actually affect your sperm production. So those medications have to be stopped at least for a while before the man will be able to produce those sperms. Okay. Then we go to the woman. For the woman, it's almost the same thing. We need to find out whether she has any underlying medical conditions, diabetes, hypertension, whether she has any heart issues, thyroid issues. We need to find out all of these things. And always make sure that both couples are at where you need them to be before they get pregnant. It is not only about getting pregnant, because if you are not fit enough to get pregnant, and then we get you pregnant, the pregnancy comes with a lot of complications. You might actually not be able to deliver that child. You actually have miscarriages along the way. You might have other complications, severe complications that come with the pregnancy. And even if you're able to go all the way to the end of the pregnancy, the woman herself might not even survive to give birth to that child. So you need to make sure that you put the woman in the category where she's fit enough. So as much as possible, as physicians, we discourage women from getting pregnant if they are not fit enough to get pregnant. So the preconception care part is really, really imperative, and it's important that you get it done. Now, once they are fit, we need to find out why they are not spontaneously getting babies, all right? It means that they've really tried and then they are not getting it. Then, so the other options is that we put the woman on medications. That is after we've done all the investigations to make sure that both of them are fine. Because for the woman, we need to do all the hormonal, right? So you need all the hormones, because it's hormones that actually help with all the fertility issues. So you need to make sure that her hormones are fine. The man too, you need to make sure that the sperm is also good. Once everything is fine, you can do certain investigations where we call HSG, hysterosalpingogram, that we'll talk about as we move on. But I just want to say that once all these tests are available and everything is fine, we do what we call ovulation induction. So we'll give you medications to make you produce more eggs. And then we'll do what we call timed intercourse. So we'll make sure that once we give you the medications, we'll track it. And then once we track it, we're able to tell how many follicles you have, and then the size. And then based on the size, we'll know when you are going to ovulate. Then we'll tell you to have sexual intercourse within that time. If that does not happen spontaneously, then we'll have intrauterine insemination. That also follows the same pattern. We make sure that we ovulate, we induce you to get ovulation, then we put in the sperm, and then hopefully you get pregnant. If you don't get pregnant with that, then the next option is what we call the IVF, the in vitro fertilization, where we make babies outside the womb and then implant it into the womb. Wow. Right? And then we have other options, what we call the intracytoplasmic sperm injection. Those ones are usually for male infertility, where they are really struggling with production of sperm.
Okay.
So the least sperm that you get are really valuable.
Wow.
So we just take one, and then we implant it directly into the egg to make an embryo, and then we transfer it to you. So those are the options that are available.
Amazing. This
I think I want to comment on the last mention. Okay. So as part of the hormonal labs we have this lab we call AMH, the anti-Mullerian hormone, all right? And most people are of the view that if they have a high AMH, that means they should be able to get pregnant. So I would like to explain that. So what the AMH does is it gives us an idea of your ovarian reserve. So let's say, for example, you have 10 ovaries left, or this month you are producing 10 ovaries. It gives us an idea but it doesn't tell us the quality of the egg you are producing. So you realize that we have some patients who have very high or normal AMH level, but then and then you stimulate them, like you mentioned, as you give medications for the follicles. So let's say the eggs to grow nicely. But when you take them to the lab, you realize that the eggs are not of good quality. So it's sometimes the women end up being depressed or being devastated, thinking there's a problem with their body. I just want to let everybody out there know that a high AMH value doesn't mean that the high quantity of eggs doesn't mean that it's of the same quality. All right. So we just want them to also understand that.
Got it. I love that. And you can really see all the huge advancement in science and technology in this part of healthcare. So let's lean more into the process of becoming a parent. Typically, you would hear before the introduction of scientific health, our forefathers really relied on maybe herbs and concoction as their sole means of having kids. What would you say to couples or let's say women right now who rely solely on that?